All right. So thank you to the organizers for giving me the opportunity to present. It's a very unique experience, and this as during the times of coronavirus pandemic, this is a good hybrid model to pursue. So I'll talk a little bit about 3D echocardiography and how we use it and how it adds an extra dimension in congenital heart disease. So here's a quick outline of my talk. We'll go through individual sections and we'll talk more about that. The first papers about 3D echo came from 1974. And over the last 20 years, with the advances in the transducer technology, improved circuit boards, and higher computing power of the echo machines, this has led to really easy applications of 3D echo in congenital heart disease. So these are the systems we use. Philips Epic is the current workhorse for 3D echo right now. We used to have an IE33 platform of Philips before, and we are also looking into some other non-Philips products, but Philips for us has been kind of ahead of the game in 3D echo. And we'll talk about the transducer, but this is predominantly used for younger kids and teenagers and older kids. We use the X51. And when we started, it did take us a long time, all day, half a day, getting a couple of 3D echoes done and post-processed. And but now with better technology, more experience, and we are able to get this done in a timely manner. Still does not, it's not like 1 minute and you're done. It does take 10, 15 minutes sometimes, depending on the complexity of the case. So this is a quick overview of the technique and technology. This is from Dr. Roberto Lang's paper that was published simultaneously in the European and American Society of Echo journals. And basically in 3D echo, a pyramidal data set is acquired, and that's acquired by stitching 4 or more of those small pyramids together. And those volumes are acquired multiple times in second. Thank you for spotlighting the video. So those videos are those pyramidal data sets are acquired multiple times in a second to play as a cine loop. And with that, we want to optimize our frame rate for temporal resolution, our spatial resolution for valves and chords and structures, and then get maximum signal and minimal artifact. And the key is anticipation. If you know that the patient has a certain lesion or has from clinical or X-rays or any other method that there is a high potential for a valve or a septal defect that you would want to profile better by 3D echo, then you should anticipate that. Sedation helps, and we oftentimes combine it with a cath or surgery for that. Depending on the size of the patient and the best window, we use the probe and either the apical, subcostal, or peristernal, the common windows we use. We use retrospective acquisition when we are doing functional quantification, whereas for anatomical imaging of structures, we use prospective acquisition. And we try either a single beat or a 2-beat or 4-beat acquisition just to optimize our frame rate and avoid the stitch artifact. And if it's an older cooperative patient, we ask them to hold their breath. I personally find cropping or post-processing on a cart quite cumbersome unless I'm doing a TE in the cath lab or the OR. I prefer to crop on a computer workstation, and then we review the data, do the measurements, and report. This is a interface. So once you connect the probe, and you can choose the layout you want. Typically, I prefer the 2D planes and a 3D plane. And then either you can have an X plane, 3D zoom, or full volume. 3D zoom is live 1 beat, full volume is multi-beat acquisition. And once you acquire that, for post-processing, I either use the plane. I previously, before iCrop came along, I used to use plane crop, but now I find iCrop quite easy and more user-friendly. Again, from Dr. Lang's paper in 2012 for optimizing the image quality, you want to slightly err on the side of overgain than undergain, because you can tone it down. Once the image is undergain, sometimes you can't see the details as much. But don't have too much on overgain. This is an example of stitch artifact, and I'll show you another example where we have a stitch artifact and how to go about reducing it. But basically, breath holds and small single beat acquisition will be helpful. And if the image resolution is not good, you can optimize the frequency, compression, and focus. So with that background in mind, so here are some of the cases. This is a case of a truncus arteriosus patient who has a moderate degree of truncal valve regurgitation. Here you can identify this leak being central. And this is the X-plane image or biplane image. Before I acquire a 3D, I personally like to get an X-plane image to see what structures I'm going to be seeing in my pyramidal data set. So if you can see from left to right, you are going to see in that data, if you, so this aortic or truncal valve in the middle, and then here the part of the truncal root and ascending aorta and the LVOT. Here's the VSD patch that has been placed at the time of truncal valve, truncus arteriosus. Yeah. Anyway, so when you do the 3D acquisition of the same valve, this is how it appears. So the left coronary cusp, which was indicated by the presence of a left coronary artery here. This is the interatrial septum, and so this being the non-coronary sinus fused with the raphe here and with the right coronary leaflet. So this is a functionally bicuspid valve, and you can see the central area of deficiency where this regurgitation was coming through. And here was that left coronary that I was trying to point to. Anyway, so you get not only pretty pictures of the valve, but there is outcome implication. So if it's a quadricuspid truncal valve and you tricuspid the truncal valve, then you can have a long, durable truncal valve competency. Here's another patient with hypoplastic left heart syndrome and tricuspid valve regurgitation. The patient is at the stage of bidirectional blend type superior pulmonary anastomosis, and this being a color compare of in an not a color compare, so color biplane image with the line going through, and this being a two-chamber plane. It's a broad jet in both the planes. The annulus was mildly dilated, but not the sole reason for the regurgitation. When we look at the subcostal en-face view of the valve, you can identify the leaflets, and the predominant area of regurgitation is around the anteroseptal commissure. But then when you get the 3D image, it becomes quite clear. So this is the anterior leaflet, septal leaflet, the inferior leaflet. This is the anteroseptal commissure, and you'll see there is a deficiency right there at the basal aspect of that commissure. That's where the regurgitation jet that we saw in, and this patient did have repair done at the time of the Fontaine. The surgeons thought that they could put sutures and make this better, and it did improve the tricuspid valve regurgitation. Here is a patient with an atrioventricular septal defect. We are imaging from the subcostal plane, and it looks probably mildly unbalanced with right dominance at the level of the annulus. But when we put 3D echo, we can see that the actual opening of the left AV valve is quite small, and actually further focusing on the left AV valve, you can identify that there are two orifice, one here and one here of that left AV valve. And so it's a double orifice left AV valve in an AV septal defect. And along with some hypoplastic LVOT and aortic valve, this patient was better suited for a univentricular type repair. Here's a patient with prosthetic mitral valve, came in with pulmonary edema, atrial tachydysrhythmias, and we were trying to identify, there was mitral stenosis with a mean gradient of 25, and the mechanism, is it acute in terms of thrombus kind of sticking on the leaflets or something? But this is an example of stitch artifact that I was talking about. It's hard to see the valve leaflets, but they seem to be opening here. With the frame rate was 29 with a 4-beat acquisition. You can imagine that with the stitch lines here that there are 4 or or so. And this, ECG is a guide as well. To see the ECG tracing, there are 4 lines that suggest that 4 beats have been used to fuse this image. So we used a 1 beat acquisition, and the frame rate definitely went down to 13 hertz. So that's not totally cool, but it still gives a clearer picture without the stitch artifact. And now you can see the mechanism probably is all this circumferential pannus formation on the mitral valve ring, and this is a pathology specimen, not of the same patient, but it gives you a perspective of this may be the reason for stenosis. Anyway, so the other lesions we find use are when there are vegetation, thrombus, any tumors, outflow tracts, aneurysms, and during interventions or peri-procedural. So here's an example. This is a 4-chamber, 2-chamber image or biplane type image. Here's this red line, if you can see, is suggesting that we are projecting on the atrial septum from the left atrial aspect. And this is the central secundum type defect. And with color flow in 3D, you can see that through that defect, the flow is all left to right. And this was a device that was used to put it in. This is from the left atrial aspect. This is from the right atrial aspect. And superior vena cava would be here, IVC would be here. And this is not encroaching on any valves or inflows. So this device was released and the patient did quite well. Then occasionally we see some structures on the devices that have been deployed, and this was brought to us. And in this patient, we can see that there is something on the device, but then when we look at the device itself and how it is supposed to endothelialize, this is actually part of that hook that is used to retrieve a device in case it embolizes or whatnot. But so that's what we are looking at, wasn't the thrombus. So, but the 3D image kind of, now that you see the hook, you kind of can imagine that structure here. So 3D helps in kind of identifying some of that. Now going to the quantification aspect, are you guys still able to hear me? So there is some background noise, but I'm hoping you guys can still hear us.
Dr. Sanket, sorry to interrupt you. Time is going to up.
Okay. Yeah, so quickly, just to show how we do the LV quantification. These are 4-chamber, 2-chamber, 3-chamber planes. And this is, we can adjust the margins, and we are able to incorporate some of the, or all of the 3D measurements in our reporting system. And same way for the right ventricle, we can, when we identify the landmarks, the model for the right ventricle can be generated with volumes. This is a patient with reported pathology, a fellow with a dilated right ventricle. So we don't use 3D strain or 3D fetal echo or 4D fetal echo that much in our lab. But here's a quick summary of what we talked about. 3D echo does add a third dimension to imaging. We use it primarily for LV function, valve anatomy, septal defects, masses, outflow tracts. 2D continues to be the workhorse. X-plane has, I like that very much, and we use it every day for 2 high resolution 2D echo images. Color Doppler still has to go a little bit better for frame rate. 3D TE is excellent for peri-procedural guidance, and it is a team sport, and with practice we can incorporate it in our workflow. These are a couple of references from American Society of Echo, but I recommend this book as well with nice illustrations of 3D echo. This is our team in Children's Mercy in Kansas City, and we thank our IT team as well and our fellows who help us out with some of this. Thank you. I'll stop sharing.